Okay, so we're now recording, and what I will do is I will essentially pass over, in terms of conversation now, to the group who are sitting in the top corner of mine, the three people sitting together with their video on, who are going to help us understand what it means around communication in patient-partnered research. So if I can ask the three of you to just quickly introduce yourself, what your role has been in patient-partnered research teams, and we'll then sort of get into some of the questions around your experience around communication.
Sure thing, Eddie. Thanks for having us. So I'll start. I'm Mike McGillian. I'm an associate professor in the School of Nursing at McMaster. I'm assistant dean research, and I'm also the lead for patient engagement at the Population Health Research Institute, and a scientist here, where we're speaking to you from.
Hi, my name's Carly Olette. Today I'm speaking as a patient partner. When I was 12, I was in 2 motor vehicle accidents, and as a result of those accidents, I developed complex regional pain syndrome, which is a chronic pain condition. So I've had chronic pain since my young teenage years, which has allowed me the opportunity since to be able to be a patient partner. I've been a patient partner on the Chronic Pain SCORE network, and then as well at the Hospital for Sick Children. I'm also a nurse by training and a graduate student as well. So I have multiple hats professionally as well as with personal experience.
And hello everyone, thanks for having us again. My name is Marissa Bird. I am a second-year PhD student in the School of Nursing at McMaster University, supervised by Dr. McGillian. I'm also a nurse by training. I work with medically complex children, and I'm just starting my patient partnership project for my doctoral work as well.
Great, thank you everyone. So hopefully people can still hear me. Well, I want to sort of get you guys started on conversation around the experiences that you've had working in patient-partnered research. I mean, Carly, you started off by talking about your work with the SPORE network on chronic pain. Perhaps you guys can give some examples of things that you've been doing around patient-partnered research, sort of set the tone.
Sure thing. So I'll go ahead and start. So there are a number of ways in which I've had the good fortune to work with patient partners. Probably one of my earliest experiences was developing a knowledge dissemination website that was really around helping 2 of those, a multimedia web-based resource center, to really help inform patients and families about conditions they were living with end-stage heart disease and pain-related issues. So one of the early experiences I had was co-designing that multimedia web-based resource center with patients, which really got into the level of what is the story that we want to tell, and really based it around filming principles. And so we co-developed scripts together, developed a conversation that was to help narrate the patient's story around the experiences of living with persistent forms of cardiac pain that are debilitating, and how best to package that information. So really co-designing this web-based resource that we ended up circulating to 167 countries and 70,000 people in 5 continents, and really working with Elsevier, the publisher, in a co-design process with patients. So that's probably one of my earliest experiences in doing this work, which I found to be terrific. Lots of lessons learned around shared communication and setting up patient partners and researchers for success in that partnership. And many of those principles that I've learned that we can talk about today, I've certainly carried on forward in other work. One key example here is the hip attack trial at Population Health Research Institute, which is really about accelerating the pathway to surgical care for people who have a broken hip, and making sure that they end up having surgery within 6 hours of the injury, because we know that many times patients will sustain all kinds of complications because of the body's response to the injury when we wait too long to have that surgical procedure. And that's really a health systems redesign trial. And so lots of great experience around engaging in co-thinking about how to best solicit patient and family experience of that intervention, and engaging in dialogue around the trial outcomes that matter most to patients and families. So those are a couple of examples, and certainly there are more, but lots of lessons learned, particularly some of the early mistakes I've made and some mistakes I've repeated, for sure, as well as strengths and lessons learned to share. Can I just mention, Eddie, so for whatever reason, you've gone dark. We can't see you anymore. I'm not sure if that matters, just so you know.
Okay. So I think maybe I only pop up when I talk. So if I do disappear, don't worry, I am still here.
Okay, thank you.
So I'll go next. So some of my experiences actually participating as a patient partner began when I was roughly 12 or 13. So I had some exposure when I was quite young. And my team at the Hospital for Sick Children, they were developing an app for youth with chronic pain. And they were in the early stages of developing it. So they wanted some feedback just about, you know, the layout of the app, things I liked about it, things I didn't like about it, the usability of it. So I had that exposure where I was brought into a project to kind of give some my perspective on what they were doing for their research project. I really enjoyed the experience. So as I got older, I was really a strong advocate that I wanted to participate as a patient, lend my experiences, share my thoughts on different research projects. And eventually I've ended up pursuing into a career interest in research and nursing as well. And then from there, I ended up getting involved with the Chronic Pain SPORE Network. So I'm the co-chair on the Training and Mentoring Committee with Dr. McGillian, and also the Pediatric Pain Registry with Dr. Jen Stinson. So I offer kind of a leadership role in both of those committees, which has been an amazing experience. And then I've also contributed with a couple of different projects, more recently with Dr. Katie Burney, where we were developing pediatric chronic pain priorities in Canada. So that project was a patient partnership led project where we actually included patients and families from across Canada to come together and basically come up with what were the most 10 important questions for that need to be answered by research for youth and children living with chronic pain. So I've been very fortunate to have some of those experiences, and I've really embraced kind of a continuum of being on a position where it's just advice and very minimal input, where, you know, to the end of the spectrum where I've been in leadership roles. So I very much enjoyed being a patient partner, and thank you so much for having me here today.
And I'll just round out that question. So my experiences in my PhD journey with patient partnership and research have been some from the academic side, and then a little bit as well starting to get into kind of the experiential side. So the three of us in this room, alongside one of our patient partners and some other researchers from McMaster, just submitted a large scoping review that we've done that looks at patient partnership in research and all about the evaluation of that. And so what are the outcomes that we can expect from partnering with patients in all types of research? What we found through that is that there's a lot out there about patient engagement, but most patient engagement is really done with consenting research participants. And so for our purposes, we were really interested in what happens when we actually have non-consenting participants as part of the research team, so alongside researchers in that capacity, so we can share some of our lessons learned from that today. And then for my own work in my doctoral studies, so we're just at the beginning, but we are also undertaking a co-design study looking at developing a digital health intervention for medically complex children and their families. So we have the good fortune to be working with some of our very knowledgeable families at McMaster Children's Hospital. We are in the active recruitment stage for anyone else who wants to participate. So if you know anyone, please put the word out. And really this is starting kind of from the ground level at this point. So our vision is to design the intervention, with our patient partners, develop it, and then evaluate it as well.
Great. So based on your experiences, obviously the topic for today is around communication, and you guys represent sort of not just the research world, but the interactions between the research world, the patient partners world, and also the health professionals world. What does good communication mean to you? What does it mean to have good communication in patient partner research?
Sure. So Eddie, I'll make a start. So in the trials we work on here at PHRI, and certainly in the work we do together, I think good communication there are some standard principles that apply, but also some highly contextualized ones depending on the people you're working with. And so I would say that for us, we try and consistently to be accessible, for one. So is it clear that you can be reached, or that if you reach out, what is that mechanism? And what are the set boundaries around when it's okay to contact and what times of day are off limits, making that very clear for people who are very good about contributing and giving their time. Consistency of communication is another one that I've certainly learned over the years. I find that over the years, I think as with a lot of research effort, even with people's own teams, there's a tendency to really focus on communication up front as something gets going, and that can slip.
Mm-hmm.
And I think in my probably early days, at least, of doing this, there probably are some times where I left it too long to report back on progress. And so I've learned well how to improve communication in that regard, but also to understand what are the best ways to communicate. Some of our patient partners really appreciate an email. Some want a phone call. Some like a face-to-face visit. So it really is important to tailor to really understand the individual. So I think accessibility, consistency, ensuring attention to follow-up, because often there's a lot of excitement in projects, and then as they get going, time passes. That's crucial, and to think through design where follow-up is an instrumental and very important part of integrated knowledge translation and other functions of conducting research. But then also really thinking through tailoring the communication for individuals, because not the same form of communication works for everyone. And I think that leads to a larger principle. And I have a story I can share when the time comes in the conversation, but being curious about people. So patient partners who engage with us and come to the table, there's of course the curiosity about what's the research agenda, but who are they as people, and what are they interested in hearing, and what would they like to get out of what's happening in the research process? And there's been some invaluable things that have happened for us just by virtue of being curious about what our patient partners might be interested in to do with the research or otherwise. So I think those are four key things I would say: accessibility, consistency, attention to follow-up, and curiosity.
Awesome. And just to kind of go off of Mike on the other spectrum of that too, I think patient partners, and I think it's a developed skill, but also learning how to communicate effectively with research team and balancing power dynamics as well.
Yes, yeah.
I know before I really gained some insight into the research world, research takes a really long time, and kind of as Mike spoke to, months where there's no communication just by virtue that there's really not much progress going on a project doesn't mean that that patients are being excluded from the conversation. It's just how it's the nature of research. So I think having that clear communication is important, as well as communicating research teams with what is actually feasible for patients. I know I worked with patient partners where physical accessibility is a concern, so making sure that accommodations are met to make sure that if patients are participating in any type of research or in-person activities or anything like that, that their needs are met. So those types of communication tactics are really important as well.
I would just echo what has been already said. It's great learning for me as well. But I think all of those principles are very important, and we know that communication plays a huge role in people's ability to participate and the safety of that interaction. So I think that those are very important points.
And I think too, probably a word we could add to the list is clarity.
Mm-hmm.
And I find no matter how clear I think I'm being, there's always room for improvement around clarity and distilling messaging around purpose so that there's a common sense of purpose in what's happening. I think also ensuring in terms of timing, particularly in our patient engagement events here at PHRI, we have learned how to work with timing in the day so there's enough space for dialogue and interaction. Sometimes we have underestimated the time to build into an agenda for those purposes and how to facilitate that interaction well.
Great. I mean, you speak to an interesting thing that sort of naturally leads me to my next question, which is around what you've talked about, what good communication looks like. You mentioned, Mike, that you had a story that perhaps you had an opinion. I mean, what sort of personal examples do you have of when you've seen this kind of communication approach, these communication approaches really work?
So one thing, and Eddie, I know it's a story that you know, but I think a really clear example for us is in the hip attack trial, which led to a whole other sub-study just based on being curious around opinions of our engaged patient partners. So just to briefly recap what happened, early in the days of the hip attack trial, which is a multi-site trial in the province of Ontario and internationally, with 3,000 patients enrolled, some people being randomized to accelerated hip fracture care versus standard care. And one of the things we really wanted to understand was what is the perceived importance of the trial outcomes? And we look at by our patient partners. So we look at an array of patient outcomes, trial outcomes, post-operative complications, post-operative mortality, and so on. But we really wanted to understand how could we inform our communication plan around what we find in hip attack based on what patients and families tell us about the importance of the event. So when we designed an engagement series, so a number of days or a series of time working with different engaged patient partners, we explained our trial outcomes in accessible terminology and had a dialogue about each of the outcomes and why it's there. And we asked our patient partners to vote using an audience response system to really give us feedback on how to prioritize our messaging. And that was very useful. One of the lessons in that for me was the exercise was very structured. And so we didn't actually, I hadn't thought ahead of time to have an unstructured segment, anything else that we might discuss. And so a couple of our, terrific patient partners, we had a break and we came back from the break and they said, Mike, this is terrific. And we can see how this is going to be really helpful, but you haven't actually left any time in the agenda for us to make suggestions. And I was like, well, isn't that a blaring omission on my part? So let's build that time in. And so we adapted the day. And they said, well, something you are not capturing at all is what is the experience of the intervention like for patients and families, and particularly family members who are alongside, and how does all the communication work in redesigning the system to make this rapid surgery happen? It was such a eye-opening experience and conversation. So, so then we asked, well, how should we inquire about this? What ways would you do it? And it led to this whole other stem where we co-designed an exit interview based on the patient's first action framework. We used that as a framing, co-designed this structured exit interview. And our patient partner suggested, let's use the audience response system because we have so many possible questions we generated based on our experience of undergoing this procedure. Let's vote ourselves and come down to an exit interview. And that exit interview is now being used. And it's led to a whole other sub-study around what's the experience of this kind of care pathway and redesigning it, which just hadn't thought of. And so I really appreciated the insight into the importance of leaving time for curiosity and open discussion. So my tendency has been at times, because of attention to concern for comfort and timing and making everything work well, to not leave enough unstructured time in the agenda. So I hope that's a helpful story.
That's great. Carly, perhaps from your point of view, perhaps for your patient with your lived experience hat on, what sort of experiences have you seen where communications worked pretty well?
So I think kind of like Mike mentioned earlier, it's really adapting what communication is best for the partners that you're working with, and that's how I found that I've stayed most engaged. So for example, within the CPN, we use a platform called Basecamp, and it serves as a communication tool for all the patient partners. And it's kind of like a platform where you can communicate with each other, you can post links, you can, it's like an open discussion forum. So it really enables the patient partners to be able to interact with each other easily, and also it serves as a communication tool with the research team. So for me, that works best for me, being electronic. I also think that communication throughout the progress of projects has been really important. So I can reflect on the project that I was involved in with Katie Burney, and she was the lead of the Pain Priority Project, where she would send out weekly updates or bi-weekly updates, or kind of as things came about, she would inform all of patient partners and their families as to what was going on. She consistently asked for feedback on different aspects of the project, even things like designing the logo. So it's really been a true partnership where we are equal, members at the table, all having a leadership role. So just opening those communication, having that form of dialogue has been really great.
Marissa, and your thoughts? I mean, obviously you've got experience as a researcher, but also you as you mentioned, you were involved as a health professional prior to this in patient partner research teams. Is there a difference in the way that you see examples of communication? Are there parallels from that point of view?
Yeah, so in terms of the role of health professionals in communication and patient-partnered research, I think that they have certainly a big role to play, especially for those of us who are involved in clinical research. Perhaps we found that patient partners may be more comfortable sometimes speaking with a member of their care team who is also involved in the research. So I think that just speaks to setting up communication in a way that patient partners and researchers feel safe, both to talk about the good things that are happening and to talk about things that are happening that are not so good or could use improvement. So we've found, certainly, I think that having health professionals on our team is really important in terms of just stewarding that patient partnership journey, and allowing them to fully contribute, and whether they speak to us as researchers or whether they speak to a member of their clinical team who's also feeding us back that information, I think that can be really valuable. So I'd say that that's a strategy that we've used that's been really successful in patient-partnered research.
Great. So we talked about the good of this. Communication obviously is one of those key things when things go bad. I'm really interested to know what happens when communication challenges arise within your patient partner teams. What are the challenges that you face, and how do you go about trying to manage those in a way that's effective to sort of move people back to good communication systems? How do you go about dealing with those challenges when those challenges arise?
So in my own case, consistently, a challenge that I've had is, and I think it refers back to Carly, something that you said at the beginning of this discussion, is not being as clear as I needed to be about expectations about how long things take in research. And so I have, no matter how I have thought I have addressed that as a team, or other individuals on the team have addressed it, or even other patient partners with our other partners have discussed, we're going to get back to you for this next step at this time, and here's why. I find that, and it's understandable that sometimes those details can be lost. If you have a busy half day, we tend to do our patient engagement activities in structured half days here. So I have found that sometimes that get lost, and a couple of times, rightly so, I have been approached to say, you know, you haven't gotten back to us and sort of left us hanging. Why? What is happening with this project? I thought we were part of it. And so, and I would say that that is absolutely right. And careful attention to that has to happen. And so one of the tools that we created that we now used based on that experience, because it is easy to forget, even if you've addressed it, or it's easy to not have it come across as clearly as you thought it has come across. So I take full accountability for any times that there's been those misunderstandings. So we now have developed a patient engagement partnership charter. And that charter we use at the beginning of every project where we involve, or when we work with new engaged patient partners who are kindly willing to join us. And we use that charter as a device to dialogue about what are the expectations around follow-up in particular, because that's a key one, and what are the roles and expectations. And there's opportunity for that to be co-developed and then documented. And we keep a research version, but also a distilled version of those expectations that we then send home with individuals after we're completed our face-to-face sessions. And I have found that using a charter to lay out expectations clearly and having it in a couple of different forms has been a really helpful tool to make expectations clear on both sides, and to also lay out, if there's a question, how do you facilitate quick access to somebody to have a discussion.
So I have a couple of thoughts as well. So my first thought too, that I've always been a strong advocate for, that patient partners in research, it's kind of like a puzzle piece, and you have to have the right patient partner with the right project and with the right research team. And I think, and I've had experiences where I didn't fit right for that project and for that research team. And I realized that what was happening wasn't working for me. And I think then in turn, I think as a patient partner, there are inherent power imbalances that exist just by virtue of research often being in a leadership role and patients often seen as more of a secondary type of role. So in those types of instances, it's really, as a patient partner, being aware of if it's not working for you, communicating that with the research team and being frank with researchers. And then I also think that communication, when it's hard to balance the power difference between researchers and patients. So I think as researchers wearing the hat, just to kind of switch points for a minute, it is making sure that, as Mike said, that as a research team, you're approachable to patients, that you're taking what they say seriously, that you're avoiding, asking them just their experiences and being tokenistic with it, and then not doing anything with anything that they're, providing in the research. Because at that point, then what's the point of having patient partners involved in your research at all? So those types of things where establishing those ground rules, establishing what you're going to do with research, with their input, with their feedback, with their involvement, I think that that's really important. And I think when those steps are missed, it's a challenging relationship to recover from. So I think right from the get-go, those are things that have to be established.
Yeah, absolutely. I just want to emphasize the point around clarity. So from this review that we've just finished doing, the biggest barrier to authentic patient partnerships was a lack of communication, especially around clarity in terms of what is the role of the patient partner and what are the terms of engagement. So we found that when researchers or patient partners or both were not clear on those things, there were some reports where actually patient partnerships were leading to emotional tolls and burnout. And just due to the fact that no one was clear as to what was expected, how much time, how much effort, we know that patient partners are not just patient partners, that we all play many roles and wear many hats in our own lives. And I think there is a danger when there's a lack of clarity around what the roles are, of overburdening either researchers or patient partners or both. So I would just emphasize that point. So strategies like having a charter having really good communication from the outset, having an exit strategy planned, and you know, letting patient partners know that, you know, it's okay at any time if this is no longer the right fit, that it shouldn't be an obligation. This is not, you know, volunteer work. This is a role that needs to be, as Carly said, the right fit for the person.
I just want to pick up there. So the clarity around exiting as a patient partner when you wish to, rather than when the project dictates, is key. And I think in the first 3 versions of our patient charter, we did not have that laid out, and it came up in a naturalistic way, and people, you know, felt a little sheepish raising those issues, and for various reasons. People are moving, people are doing other things, but including that in the terms up front removes any, it's helpful for removing feelings of anxiety around having that conversation, for sure.
These are great, and I think I'm hearing answers to my next question already, which is the final question I'm going to ask before we let everybody else who's on the webinar ask you questions. What would you say are, you know, the two or three biggest things that we would need to take away from this webinar, from you guys, around what communication in patient partner research means? What are the things that people need to really understand and take forward to make sure that communication is effective, is appropriate? What do you think is the way for people to do that?
So as we've been talking, I've been thinking around this question, and I think that sound communication really only comes from a place of authenticity and genuineness in the work. And I think that it stems from, back to points you've both said, about really thinking through early, what is the purpose of an engaged patient partnership in whatever the project happens to be, and then engaging in co-thinking around roles and what that will look like, so that the design of it is intentional. And, you know, as projects evolve, you learn, and then you want to bring in others to consult and work with you and have input along the way, and that's fine. But I think that when things are rushed or not thought through well, is when problems arise. And I think that's true of anybody working in teams in research, patient partners or otherwise. So I think forethought and authenticity around and clarity of purpose are key drivers of good communication.
And I would just add as well, I think adaptability, both from the patient perspective and the researcher perspective, right? It is a relationship that goes both ways. And I think really coming at it from the perspective that you can learn from each other, and that every research project, you know, I think it's a learning experience, and I think every research project is unique in that sense, that you're going to learn things as you move along. So I think being adaptable to both sides is helpful. And then I think also making sure that even simple things like the language is accessible, that the terminology and the jargon is avoided, so that patients really have a clear understanding as to what they're being involved in. And then also from the patient perspective as well, not being you know, afraid to share their thoughts, afraid to share their views on things. And I think that having the confidence to do so and building those trusting relationships with the research team really fosters that, to really have a really good patient partnership experience.
Yeah, I think the only other thing I would add, and it's really just to echo points that have already been made, is just creating a safe environment for good communication. So you spoke about, you know, feeling safe or having the confidence to speak up. So I think as researchers, we can model that. And that's really important, but also just kind of in your terms of engagement, saying right up front, hey, you know, if things aren't working well, we do want to know about it, because that you're not going to have a fruitful partnership if there's, you know, all these things going on behind the scenes that everyone's afraid to speak up and say. So I would just say, you know, really trying to create that communication safety in that environment is key.
That's fantastic. And I'm gonna try and be pithy and summarize in one sentence. It sounds like what you're saying is communication is not about the message, it's about the relationship. So the messages are what come through from the relationship, but it's actually about building that relationship and maintaining it. And the communication is all about that, rather than getting a message from one person to the next. It's about the relationship building.
First and foremost,
yeah.
I would agree.
Yeah.
Fantastic. And with that, I'm going to stop asking questions, and I'm going to open it up to the floor. So if you want to ask a question, you should be able to unmute yourself in the top right-hand corner of your little picture. Feel free to ask a question. If you are not sure that you want to unmute yourself or you're having trouble, there is a chat box available as well. So please do ask questions in the chat box, and I will open it up to anybody who wants to ask questions of the group of Carly and Marissa and Mike. Give people time to unmute themselves.
My eyes are bad.
Okay, so we have one in from Zara Bimani at Captic, and talking about using Twitter chats as a communication tool, and whether that's uncovered much insight and the capacity for using that. Have you guys got experience of that?
Yeah, so I think I know in the pain world anyway, there's some great communication going on Twitter. Even just proceedings from conferences and different meetings like that to kind of know what's going on. I think if, like I said earlier, like if you're a patient partner, if that is a method that works for them, if they'll use it, if they're comfortable with it, if they have the experience and the knowledge and the tools and how to engage with it to get the most out of it, then by all means, right? But if it's something that they're not going to necessarily, if it's not a good fit for them, then that's not a good method of communication for them. So it's adapting to your patient partner. But I've used Twitter and I love it. It's great. Yeah.
So in my own case, I have used, so patient partners and I have used structured Twitter chats that are advertised ahead of time, where we're having a conversation between researcher and patient or clinician and patient about the experience of what we're doing, and advertise it as an engagement tool, but have set it up such that the conversation is live, and then other people are assisting us to tweet as we have that conversation. So, and that's been a fun way to do it at times as well.
Mm-hmm. Well, and I think that like the one nice thing about Twitter is that you only have a limited amount of characters, so you have to get your message across concisely and to the point, right? Yeah. You can't be filled with jargon, you can't be long and drawn out, so it's to the point and it's accessible.
Yeah. And it can be a nice tool as well, even for outside of your immediate patient partners on a project, just for general knowledge dissemination. You know, there are certain people and organizations that I follow on Twitter because I know that when their next meeting comes up or you know, when they're presenting something, they're gonna post it on Twitter. And I think it's just like, it's a nice way for the wider academic and non-academic community to communicate your message. So yeah, I've seen success with it as well.
Mm-hmm.
Great. Zara, I can see that you've got your microphone. Are you happy with the answers?
Yes, thank you everyone. We're in the process of establishing our group of patient partners and trying to find individuals who want to be interested in ICU research and quality improvement endeavors. With that being said, I think earlier it was mentioned that Twitter is a good tool if the patient partners sort of resonate with it. And we're finding that out still through experimentation, whether it resonates, whether like we had a small turnout yesterday during our Twitter chat, which was marketed in advance and happened in a very structured way. But we're also leaning towards like a multi-pronged approach, using Twitter and using in-person events which we've had in the past, and then using surveys that can be found on posters in ICU rooms by, you know, taking a picture of the QR code. So just a multi-faceted approach. Are there research groups here that have done that? Does anyone have thoughts on using multiple ways in getting, and does that, our assumption would be that it would bring a diverse group of individuals if we were to use different methods. Does that does that cause confusion? Does anyone have experience using multiple approaches?
So, Zara, I really like what you're saying, and I think that different things work for different people, absolutely. I wonder if you're familiar with the CMAJ supplement that myself and a number of others worked on in partnership with OSU. Mm-hmm. Around patient engagement, and they were projects funded by Ontario Sport Support Unit Impact Awards. And so there's a special issue of the CMAJ that speaks to really practical ways that engagement partnerships were formed. There's 17 different pieces around different ways that partnerships were forged and how they were executed and researched. So that it might be a helpful collection of different examples for you. Mm-hmm. I think something that I've learned well is there's lots of theoretical material out there to give guidance, but also it's great to be creative and to use your instincts about trying different ways out. Don't feel constrained by some frameworks present the conceptualization of the engagement process really informal ways, but there are many ways you can try, and I think it's great to be creative. So supplement might be a helpful tool to you in terms of practical means.
I'll look at that. Thank you.
And I think you just saw some feedback from Annette, who's one of the key members of our patient partner working group, about the timing of Twitter chats and when they're available, when people are available and things. Maureen, you want to jump in?
Yeah, I'm going to unmute myself, and I'm going to put my video on too.
Oh, fantastic.
That doesn't work. Okay, but I'm unmuted. I can't get my camera on for some reason. Thank you so much. Great presentation. My name is Maureen Smith, and I'm one of the patient partners at the Patient Partners Working Group at OSU, and I'm also a patient partner on a couple of research projects. And I'm very interested in your charter that you talked about, and I've never heard of that before. So when we do presentations to our partners, we make sure to tell them, we understand if you have to leave the study, et cetera, because, in my case, it's families so parents of children who are quite ill, and or other things that can just happen in life. But to have it down in a charter, I think is a really good idea. So my question to you is that charter co-produced?
Yes. So the way we do it is that we draft the terms up, and then for any particular project, when we usually, depending on what the project is, we have different groups of engaged patient partners at different times. And so, for example, in the SmartView trial, which is a trial of remote automated monitoring, we wanted to co-design that intervention right from the beginning. And so we worked with engaged patient partners who helped us to distill their story about what happened to them after surgery and what complications they sustained. And so we knew that in terms of scope, that was really specific. Before we thought through the rest of the trial, it had defined boundaries. And so we fashioned a charter about that specific activity. And we came to the table with what we thought were the activities and how this communication would work, how the follow-up would work, how our patient partners would hear about it afterwards, and laid out those terms. And these, the population that the SmartView trial is designed to serve are individuals over the age of 65 who have had cardiac or major vascular surgery. And so we crafted up those terms, brought them to the table with a few of our patient partners, and had some dialogue about, this is how this is going to look. What do you think of these terms? And then we get feedback, and we've done that for everyone. So, and a common feedback item that we get is that I often either will overestimate or underestimate the time it will take in terms of follow-up and the check-ins and the frequency. And so I find that with different groups, based on what we're doing, we tailor those terms according to preference. So there's always an exercise where we, in the early phases, depending on stage of trial and the group that we're engaging, go over the terms of the charter and receive feedback and then modify it from there. We usually have it up on a screen so that everybody can see it, and we co-craft any of the revisions, but we do come with a template as a place to start.
Well, that's great. I had an experience with our project where we weren't communicating, and I pointed out to the team that we needed to get a newsletter out. And one of the responses was, "Wow, I thought I had been fired," from one of the participants. And I thought that was really sad. Like, I said, we're really not doing our job if that's what people are thinking. And I had said to the team, people don't understand. We really need to get it out there. So after that, we had quarterly, like what we call the seasonal update. We did that for the whole 2 years to make sure that but that first response, of this valued person on the team who thought that he had been fired and had done something wrong or said something wrong, really resonated. And so I think this charter, is there any way that you're able to share that charter? Or I understand that it's tailored to your specific project, but maybe some of the just general guidelines of what you've included in the charter might give it.
Absolutely, yeah, I can share with you a sort of a template, things to think about for sure. So
Right.
if you reach out to me by email, happy to share.
Okay.
This is a question that came up from a number of people on the chat box. If you have something to share, then we'll happily share it through the OSU website and other places as well. So
Great. Okay, thanks, Eddie.
great.
Thank you, Maureen, for your question.
Do we have any other questions? Okay, so I'm assuming that there's not a bunch of people who are trying to unmute themselves. Obviously, if there are further questions that relate to communication in patient-partnered research, the OSSU website and the OSSU email, which is ossu@ossu.ca, are a good way to sort of start those conversations with us in order to try and get more information. Before people go, we do have a little poll. So every time we do one of these webinars, we want to get some idea around what people think the next webinar should be based on what we've heard from the Patient Partners Working Group, what we've heard from patient partners across the province. So we've got a little poll here of sort of 4 different issues that we think are important ones to patient partners in Ontario. So if you can have a quick vote on whether there are which of those you think might be the one that might be of interest to you if you were wanting to come and listen next time. This will help guide us in our topic identification for the next ones. Also be aware that if your choice isn't the one that gets selected this time, doesn't mean it won't be ever talked about. So let us know.
We're on one laptop and we're arguing about which one to pick.
Yeah.
You guys can also, I will have this up on Twitter and on our website as well. So this isn't the only chance you'll get to vote on it. So if you do want to come back and you're really insistent and you've got all your friends to vote for one of them, then feel free to send them on, and I'll make sure that's publicly available as well. But I do want to say thank you. I mean, you're getting thank yous from everybody else, so about how great the session was, and I will echo that. Maureen, are you still on?
Yes, I am. I just want to, on behalf of the Patient Partners Working Group, thank you and the 3 of you for this great presentation. As everyone's aware, there are a multitude of documents out there telling us how to do patient engagement properly, but there is nothing to compare to hearing the 3 of you giving us specific examples and just to share in your enthusiasm and the obvious respect that you have for your patient partners. So thank you so much for taking your time, and to all the participants who joined in on the call on this very busy week. I think last day of school for people in Ontario and graduations. So incredible timing, and just a big shout out to all of the people who are joining the webinars, and especially our 3 presenters today who are leaving us with a lot to think about, but especially the enthusiasm and how great it can be when a patient partnership is done in such a respectful manner to the patients. Thank you.
Thank you so much.
Thanks for having us.
And all I can say is that Maureen said everything far more eloquently than I ever could. So thank you everybody for signing on. Thank you for putting your information in the poll. And yeah, there will also be information about what the next webinar might be online. We'll get that up and running. This webinar has been recorded, so the recording of the webinar will also be going up. Thanks again for everybody. Thanks particularly to Marissa and to Carly and Michael for your input on this. And yeah, take care. Have a great Canada Day weekend, everybody.
Thank you. You too. Thanks for having us. Take care. Bye-bye.